Hi, and welcome to my presentation on Frank, who is diagnosed with hypertension. Frank is a 68-year-old male who has a history of poorly managed stage 3 hypertension, which he manages using medication called Twinstar. He also has a history of depression, but is in control of this without medication. Frank has a strong social network and is motivated. He has a relatively healthy diet and does Pilates twice a week. Frank has come to see us as he would like to exercise safely with hypertension, improve cardiovascular fitness, and increase strength. Some barriers he faces are that he works full-time, so that time and fatigue could be a limiting factor, and he is hesitant of HIIT training or HIIT training. In order to help Frank, we first need to understand what hypertension is. Hypertension is defined as consistently elevated blood pressure. Blood pressure is typically reported as a ratio of systolic pressure, which is the measurement of force exerted on artery walls during heart contraction, to diastolic pressure, which is the pressure when the heart relaxes. The prevalence of hypertension rises with age and is a manageable risk factor for several leading causes of illness and death in older adults, including stroke, ischemic heart disease, kidney dysfunction, and dementia. According to the Australian Burden of Disease Study Database, elevated blood pressure is a significant contributor to early death and disability in Australia. It is estimated to account for 43% of coronary heart disease, 41% of strokes, 38% of chronic kidney disease, 32% of the burden from arterial fibrillation and flutter, and 3.6% of dementia. Despite available treatments and awareness efforts, hypertension remains widespread and poorly controlled, leading to serious health risks. Key barriers include medication side effects, non-adherence, and lack of personalized care. Many patients stop treatment or fail to monitor their blood pressure, increasing the risk of complications. Long-term control depends on patient education to support consistent lifestyle changes and medication use. Current lifestyle guidelines emphasize lowering sodium intake, boosting potassium levels, and incorporating personalized exercise plans alongside medication when needed. This comprehensive patient-focused strategy offers a framework for improving blood pressure control, lowering cardiovascular risk, and effectively managing hypertension across varied populations. As we can see from the chart below, we know Frank is diagnosed with stage 3 hypertension. A recent meta-analysis of 34 studies involving over 1,700 participants found that 30 minutes of aerobic exercise per week reduced systolic blood pressure by 1.78 millimeters of mercury, diastolic by 1.23, resting heart rate by 1 beat per minute, and mean arterial pressure by 1.37 millimeters of mercury. This suggests that aerobic exercise can significantly lower blood pressure in a dose-dependent manner, with the most substantial reductions occurring at 150 minutes per week. Aerobic and resistance exercises are keys. Studies indicate that both high-intensity interval training, or HIIT, and moderate intensity continuous training, or MICT, help reduce blood pressure in adults with hypertension, with HIIT producing a more significant decrease. Additionally, for hypertensive patients, HIIT may lead to greater improvements in VO2 max compared to MICT. More recently, isometric resistance training, or IRT, have also been shown to be effective. The below chart was taken from the Exercise and Sports Science Australia, and it will aid us in the exercise prescription with Frank. Displayed below are Frank's test data as compared to the norm. We can see that his resting heart rate is low. This could be due to his medication, which is an angiotensin II receptor blocker and calcium channel blocker. His BMI is 34.7, which falls within the obese category, and his waist to hip ratio exceeds the recommended range. Combined with elevated blood pressure, these factors may increase his risk for additional health issues. His HDL is borderline at 1 millimole, while his LDL is slightly elevated. For individuals at higher risk, LDL should ideally be below 1.8 millimole, and if not managed, this could increase his chances of developing atherosclerosis in the future. Before we can begin his sessions, we also need to understand what his relative and absolute contraindications are. This is to help minimize the risk of harm to Frank and ensure he is working out safely under our care. It is important to note that if we notice any of these absolute contraindications, we must stop exercise gradually, of course, and seek medical guidance. Some of the absolute contraindications are a recent myocardial infarction, chest pain, dizziness, and shortness of breath. And some of the other safety considerations are, before starting any exercise, his blood pressure should be checked to ensure it's not over 180 or 110, And if during exercise his blood pressure rises to 250/115, exercise should be terminated. We should also check for medication compliance. And with the medication he is on, we must be mindful during his session, as it can induce fatigue and create dizziness. We need to ensure an adequate warm-up and cool-down is administered, and ensure correct technique is used during these sessions. These are the short and long-term goals as a practitioner we should hope to achieve in order to help Frank in his journey. These also line up with Frank's goals and why he has come to see us. For his short-term goals, we would have him follow a structured workout plan, exercise safely with hypertension by guiding him with the correct technique, maintain exercise adherence and consistency, and adherence to his medication. Some of his long-term goals are to reduce his blood pressure, increase his muscle mass, reduce his weight, ideally his body fat percentage, increase cardiovascular fitness, and maintain 150 minutes per week of cardio. To support Frank in reaching his goals, we will conduct additional assessments to establish a baseline of his current fitness level. This will allow us to tailor the intensity of his strength sessions appropriately and provide Frank with a clear and objective measure of his strength and cardiovascular fitness. The chosen tests include a 10 repetition max on his leg press and chest press, a hand grip test, and a 6-minute walk test. The 10 RM is widely regarded as a good measure of assessing maximum strength. It is valid, reliable, and a safe method that is strongly linked to various health indicators and is suitable for use in strength training programs for older adults. The 6-minute walk test is a simple submaximal assessment commonly used to evaluate functional exercise capacity. Clinically, it serves as an objective tool to assess functional status, guide exercise prescription, and help predict health outcomes such as morbidity and mortality. Based on current research, Frank's exercise plan will include a mix of resistance training and moderate intensity cardiovascular training, or MICT. MICT was chosen over HIIT, as although HIIT has shown to result in greater blood pressure reductions, elicit greater improvements in VO2 max, while managing to accomplish this in a time-efficient manner, MICT may be a safer option right now for Frank given his training experience. After approximately 8 weeks, HIIT may be introduced if his fitness levels improve. To assess intensity of resistance training sessions, we will also use the Borg Rating of Perceived Exertion Scale, or RPE scale, and to monitor his cardio intensity, we will use a Covenant formula to calculate Frank's heart rate reserve. Using this formula, Frank's target heart rate for his MICT, which should be between 40 to 59%, will be 98 to 118 beats per minute. We would also advise him to try and maintain this heart rate training zone during his other training sessions. Walk-in, Pilates, and he can keep track of this using a heart rate watch, either Apple or Polar. And this would be his weekly plan. Ideally, we would have 2 in-clinic sessions on non-consecutive days, and he would also participate in Pilates twice a week, which he likes. And this is important because if he likes a particular session or class, he is more likely to be consistent. Additionally, we have him walk in either at home, around the block, or on a treadmill at the gym once a week for 20 to 30 minutes at his heart rate reserve. We would aim to build up to the 150 minutes per week of aerobic training as per the recommended guidelines. As the weeks progress, we will increase his walks to 30 to 40 minutes. These would be his 2 in-clinic sessions for Frank. Both start with an appropriate warm-up and end with a cool-down and static stretching. Session 1 is primarily an anterior-focused resistance training session, while Session 2 is more posterior-focused. They both start with compound lifts such as a goblet squat, chest press, or a row, as they recruit more muscle fibers and are more taxing. As the workout progresses and fatigue sets in, isolation movements are selected. Initially, we have Frank doing 2 sets of everything at a rep range of 8 to 10 and RPE of 10 to 12. Tempo is kept at a 2-second eccentric and a 1-second concentric for all the exercises. Regression and progressions are available to help us modify the exercise if he finds it either too difficult or too easy to perform. For instance, if Frank is unable to perform a goblet squat to a box, we can either adjust the height of the box or ask him to perform a leg press instead. Likewise, we can also adjust the tempo to make the exercise harder. The cardio protocol for each session is below. Due to time constraints of the session, we might not be able to run a 20 to 30 minute cardio session as per the literature. However, it is just a starting point for Frank, and this may also elicit improvements to his cardiovascular system, as we would like to incorporate a HIIT session in the coming weeks. This is what the final week of Frank's resistance training program could look like. The progressions we have made are: we have increased his sets from 2 to 3, increased his reps from a range of 8 to 10 to a range of 10 to 12, and increased his RPE from 10 to 12 to 12 to 14. There has been an overall increase in volume, and in the coming weeks, we would like to progress him in exercise selection as well, as seen on the progression column. For example, instead of a chest press, we would like him to progress to a dumbbell bench press. Instead of a machine row, we would like him to progress to a seated cable row, and so on. And below would be the HIIT protocol implemented. We have decided boxing would be a good option, as Frank might enjoy this style of training. Thank you.